All right, welcome to This Explainer. Today, we're diving headfirst into a high-energy, rapid-fire review of post-transplant infectious diseases. If you're prepping for the boards, you already know this is a notoriously tricky topic. It's this massive, high-stakes balancing act full of complex, opportunistic infections. But don't worry, we're going to go through the absolute highest-yield concepts together and get you ready for exam day. Here's a quick roadmap of what we're covering. First, we'll map out the post-transplant timeline. Then we'll tackle CMV, the ultimate boss, followed by other high-yield viral suspects, fungal and bacterial foes, and we'll wrap it all up with some classic GVHD exam pitfalls.
So let's kick things off with Section 1, the post-transplant timeline.
The starting gun literally fires the second the transplant is complete, right? And that creates this highly predictable timeline of risk that examiners absolutely love to test purely based on the calendar. So in the first month, we're mostly dealing with early technical complications, surgical site issues, nosocomial bacteria, and donor-derived infections. Then, from 1 to 6 months, we enter that classic opportunistic window. This is exactly where things like PJP, CMV, and EBV strike, well, assuming prophylaxis isn't masking them. And beyond 6 months, if the graft is functioning beautifully, the risk actually shifts back toward late, regular community-acquired infections.
Moving right along to Section 2, CMV, the ultimate boss.
Now, CMV is a massive headache, mainly because of its indirect effects. It drives up the risk for graft rejection, fungal infections, and just overall graft dysfunction. But here's the really interesting part, and it's a classic exam trap: the stark contrast between solid organ and stem cell transplants. Listen up, because in solid organ transplants, your primary infection risk is highest with a positive donor and a negative recipient. But in stem cell transplants, it's the exact opposite. It's highest with a negative donor and a positive recipient. Why? Because the patient reactivates their own latent virus, but those brand new seronegative donor stem cells don't have any T-cell immunity to fight it off yet. Another crucial distinction you need to lock in is CMV syndrome versus tissue-invasive disease. What's the actual difference? Well, CMV syndrome gives you fever, malaise, myalgia, maybe a moderate drop in white blood cells, and a mild bump in liver enzymes. But to formally call it tissue-invasive CMV disease, like, say, CMV pneumonitis or GI disease, you absolutely must have histopathological proof of tissue invasion and damage on a biopsy. No biopsy proof, no tissue-invasive diagnosis. Okay, here's a major pharmacology trap that totally caught my eye. Valganciclovir, which we use all the time in solid organ transplants, actually covers HSV and vis-a-vis really nicely. But letermovir, which is your go-to prophylaxis for LOHCT, it has literally zero activity against HSV or vis-a-vis. Assuming letermovir covers HSV on the exam will cost you major points, and in real life, it could cost a patient. You've got to remember to add acyclovir concurrently. And while we're on the subject of drugs, keep these rapid-fire pharmacology one-liners in your back pocket for when CMV gets tough to treat. Ganciclovir wrecks the marrow, so you have to watch out for severe myelotoxicity. And if you have to switch to foscarnet because of resistance or toxicity, well, remember that foscarnet destroys the kidneys and completely trashes the patient's electrolytes, specifically dropping their calcium, magnesium, and potassium. All right, on to Section 3, high-yield viral suspects. While CMV is definitely the boss, its viral cousins are just as tricky. Put your exam coach hat on for a second. Imagine you're reading a vignette. A post-HTCT patient suddenly develops short-term memory loss and involuntary movements, maybe some tremors. But here's the kicker. There is absolutely no fever and no altered consciousness at first. What reactivated virus should instantly pop into your head? Boom, it's HHV6 causing limbic encephalitis. And if they throw an MRI image your way, your eyes should dart straight to the temporal lobes, looking for that characteristic bilateral amygdala involvement. Yes, we treat it with ganciclovir or foscarnet, but spotting that exact clinical presentation is what's really going to get you the points. Then there's the BK virus, which has this crazy dual nature depending on the transplant type. In a kidney transplant, the BK virus goes straight for the organ, causing polyomavirus-associated nephropathy, or PVAN, which can actually lead to allograft loss. But if you're dealing with a stem cell transplant, it typically causes hemorrhagic cystitis. Think dysuria and hematuria. Either way, since there's no silver bullet antiviral for it, your primary strategy across the board is to reduce the patient's immunosuppression. For EBV-driven post-transplant lymphoproliferative disorder, PTLD for short, there's one specific scenario to burn into your memory: the pediatric, D-positive, R-negative intestinal transplant patient. That is your absolute highest risk scenario for this EBV-driven B-cell lymphoproliferation. If you see it, the first step is always to reduce immunosuppression. If that doesn't work and the cells are CD20 positive, you hit them with rituximab.
Let's shift gears to Section 4, fungal and bacterial foes.
Now, when immunocompromised patients get fungal or bacterial infections, the presentations are often super atypical. That makes it perfect fodder for tricky exam questions. For example, do not fall for the trap of looking for a halo sign on a CT scan in a solid organ transplant patient with aspergillus. It almost never happens in this population, unlike in hematological malignancies. Also, you've got to remember that serum galactomannan is poorly sensitive in solid organ transplants. You really need a BAL galactomannan. And finally, whenever you diagnose aspergillus, you must always rule out central nervous system dissemination. Here's another one they love to test. When treating tuberculosis in transplant patients, avoid rifampin. Why? Because it's a fiercely potent CYP450 inducer. If you give rifampin, it will rapidly chew up the patient's calcineurin inhibitors, like tacrolimus, and you will accidentally plunge your patient right into acute organ rejection. No way we want that. So rifabutin is strongly preferred here, as it's a much weaker CYP inducer. Okay, you've got to hardwire these mandatory CNS rules into your brain. If the vignette points to cryptococcus, which usually shows up pretty late, like 1 to 3 years post-transplant, your immediate reflex must be a lumbar puncture with an opening pressure check. If the clues point to nocardia, pulmonary nodules in an immunocompromised host, a brain MRI is absolutely mandatory. Why? Because a whopping 25% of cases involve CNS dissemination. Oh, and remember to empirically hit nocardia with linezolid. Finally, let's wrap up with Section 5, GVHD exam pitfalls. This brings us to the ultimate paradox of graft versus host disease, where solving one problem violently creates another. It's a classic cascading scenario on the boards. Let's say a stem cell transplant patient develops acute GVHD of the bowel, injuring their mucosal barrier. To save them, you have to give high-dose corticosteroids. But hitting them with high-dose steroids essentially sends out an open invitation for aspergillus. Because of this massive risk spike, starting posaconazole prophylaxis becomes absolutely mandatory. On the flip side, if the vignette specifically mentions chronic GVHD, your brain should automatically jump to functional asplenia. And the moment you think asplenia, you target the most important encapsulated pathogen out there, Streptococcus pneumonia. These patients absolutely need penicillin prophylaxis. All right, let's pull all this pure exam gold together. Take a mental snapshot of these high-yield facts right here. Notice the starch contrasts, the flipped CMV risk based on donor and recipient status, relying on reducing immunosuppression for the BK virus instead of giving antivirals, recognizing that early limbic encephalitis of HHV6, sticking with TMP SMX for PJP, and jumping straight to linezolid for nocardia. Lock this into your memory. Leaving you with this to ponder as we wrap up. How do we continually perfect this delicate tightrope of transplant pharmacology? How do we save that precious graft without completely surrendering the host to opportunistic invaders? Remember, every single treatment choice and prophylactic adjustment alters that balance. Keep studying, keep asking the hard questions, and you are absolutely going to crush this on exam day, and more importantly, in the clinic. Thanks for hanging out and learning with me today on this explainer. I'll catch you on the next one.